afternoon, everyone. Thanks for joining us today. It's certainly a pleasure to reconnect with all of you in Florida. My name is Ken DeSergio. I'm a program director with the National Center on Substance Abuse and Child Welfare. But many of you may know that I've worked in Florida for a number of years, and I still reside in Tallahassee. So it's my pleasure to work with you, and we look forward to working with you over the course of the work that you're doing on family-centered practice in the three innovation items. I'd like to take a few minutes to introduce today's presenters. First, I'd like to introduce Dr. Nancy Young, who is the director of Children and Family Futures, California-based Research and Policy Institute, whose purpose is to improve outcomes for children and families affected by substance use disorders. Nancy serves as the director of the federally funded National Center on Substance Abuse and Child Welfare, which provides technical assistance to states in support of their efforts to enhance cross-system collaboration for the benefit of affected families, and develops and disseminates information on advances in policy and practice in this field. Nancy's also done, over the years, a fair amount of work here in Florida, going back to some work in the mid-90s in Jacksonville with the Clark Foundation initiative and neighborhood partnerships, and then when Florida was one of the first in-depth technical assistance sites under the National Center for Substance Abuse and Child Welfare. Welcome, Nancy. I'd also like to introduce Ansley Stark. We have a change in the agenda today. Frank Scafidi with the Village South in Miami was taken ill late yesterday. And Ansley Stark, Children's Services Center Director for the Village, was a co-presenter and will be presenting exclusively the work that the Village is doing today. And Ansley's a clinical psychologist with over 25 years of experience and also a licensed mental health counselor. And as I mentioned previously, she's currently the director of the Children's Services of the Village in Miami. What we'd like to do today is we will introduce some work that the National Center has done and some publications to the Substance Abuse and Mental Health Services Administration on family-centered practice. I'd also like to recognize and thank Ron Menard and his team with FMHI for putting the webinar together, and Matt Claps and Sally Bond. Most of you know Sally, who's the Chief of Policy and Practice in the Department of Children and Families, Family Safety Central Office. Matt, who's also champion for the Miami site and was in Central Office and very supportive and helpful in getting the word out on this webinar as well. So welcome, and let's proceed. The National Center on Substance Abuse and Child Welfare is a program that's jointly funded by SAMHSA, Center for Substance Abuse Treatment, and the Administration on Children and Families, Children's Bureau, Office of Child Abuse and Neglect. The National Center was funded right around 2002 following what I consider one of the seminal works on substance abuse and child welfare, and that was the Blending Perspectives, Building a Common Ground report to Congress on the effects of substance use and abuse on families in or at risk of entering the child welfare system. The mission of the National Center is to improve systems and practice for families with substance use disorders, again, who are involved or at risk of entering the child welfare system. We work jointly with sites throughout the country to provide technical assistance, both in an in-depth technical assistance program, and we also work on an initiative right now called the Regional Partnership Grants, which is funded by the Children's Bureau in partnerships throughout the country, 53 grantees working on substance abuse and child welfare, collaborative practice to improve outcomes for children and families. A little background for today's webinar. I want to spend a few minutes talking about the context for today's webinar. I had the pleasure of joining the first quarterly meeting of the core teams down in Miami back in November, and at that time I presented some of the work that the National Center for Substance Abuse and Child Welfare would be offering and partnering with the Department of Children and Families and all of you in the innovation sites in work in response to Florida's Child and Family Services Review. So briefly, we want to talk a little bit about that and kind of bring you up to date on some of that work that's progressing and what the next steps are as we work with not only central office, but looking forward to work with you in the innovation sites as well. Nancy Young will present an overview of family-centered treatment for women with substance use disorders, and included in the information, both in the handout section of the presentation as well as information that was sent out prior to the webinar, are the monographs that were published by the Substance Abuse and Mental Health Services Administration on family-centered treatment for women. And then we've invited the Village, WestCare, in Miami, so those of you in Miami know the Village, to talk about the work they've done on family-centered practice, and in particular some of the partnership that they have with the Dependency Drug Court in Miami and working with their colleagues in Miami as well. Florida's technical assistance request included these areas to the National Center on Substance Abuse and Child Welfare. In essence, to review the assessment processes and tools that are used to work with families in the child welfare systems for substance abuse and mental health content, and to look at collaborative practice, and to help facilitate improving the service array. Now, we fully well recognize that as innovation sites, you're among the best of the best in Florida, if not the best, and that the work that you've been doing, not only in implementing family-centered practice as an innovation zone, but historically the collaboration between substance abuse and mental health and child welfare is very strong in your areas, and we recognize that, and we compliment you for that work and recognize that as a result of that work, you are an innovation site for implementing family-centered practice as well. We will, as part of our technical assistance response to Florida's TA request, we are planning on working with each of the innovation sites, as I mentioned in November. And in the audience today and joining us on today's call is Pam Baston, who's a former substance abuse director here in Florida with experience implementing a substance abuse treatment program for women in the Keys. And Pam will be one of our consultants working with Miami innovation sites. And I'll be working with the other two innovation sites in Circuit 3 and 8 and Circuit 1. Florida's quality improvement goals, in response to the Child and Family Services Review, and you're probably very familiar with all of this, and the 6 areas that were identified for strengthening Florida's child welfare system, and certainly our work in strengthening and supporting you in improving collaborative practice across substance abuse, mental health, child welfare, and the court system. So today's webinar is designed to complement the 3rd bullet that you have been working on and developing and phasing in family-centered practice. And so we're going to talk about what that means for family-centered substance abuse treatment services. A key concern in Florida's quality improvement plan deals with family engagement and the challenge, family engagement, the challenge of engaging families, and recognizing that family engagement is really a cornerstone of both child welfare and substance abuse and mental health services. Family-centered approaches have become more critical, engaging and retaining families in services, both in child welfare and in substance abuse and mental health, particularly when we recognize a greater emphasis on serving families on a voluntary basis. A number of you are implementing differential or alternative response systems. The number of children at home care has been reduced significantly in Florida in the last 3 years. That's true in most jurisdictions around the country. So engaging families in a higher proportion of families in essentially what are voluntary services without judicial oversight, becomes more of a challenge and requires creative strategies for engaging families, and also creative strategies and family-centered strategies for retaining families in treatment services once referrals are made and once the connections across systems are made. And we're going to talk today about some of that work on the substance abuse treatment side particularly. We've come a long way. I think we've come a long way from the old days of here's a referral, here's a phone number, get help and let us know how you're progressing, in terms of working with families and helping them connect to needed community supports and services. And so today's webinar is going to talk more about what that means on the service array side for substance abuse services. And with that, I'll turn it over to Dr. Young. Nancy?
Great. Thank you very much, Ken. I'm assuming you all can hear me okay. We have some question on that, but thank you very much for your time today and interest in this topic. We appreciate very much you putting this on your calendars and participating in this. I have to say in those introductions, as Ken was talking about my work in Florida many years ago, that visiting Pensacola probably 14 years ago and meeting folks who were working there in the family drug court was, I think, one of my very first experiences at a family drug court. So I appreciate very much that you folks are keeping at it. I know it's been a long time that you have had this real focus of attention on serving families that are in the child welfare system and need services from substance abuse treatment. So I was asked to talk today about a couple monographs that were produced by Children and Family Futures with the Center for Substance Abuse Treatment. And the lead author on the first monograph that I'm going to talk about was Deborah Werner, who has had a long career in serving women and children and looking at what this means in terms of trying to put together, I'm sorry, I got distracted there, what this means in putting together the services that are needed for families across systems. So this first monograph that I'm going to talk about was created in bringing together experts from around the country and talking about what does it take to serve families comprehensively? Where has the field been and where are we going? What's the future in serving children and families with substance use disorders? And this work group that spent a few days together came up with some principles about what does this mean to do this in a way that is comprehensive and looks at all of the different issues that families come to treatment with and work comprehensively across systems. And develop some principles. And I think one of the key ones was that women define their families, meaning that how that particular person defines who is coming into services with them is key in who actually needs services. Some of the other principles that were talked about at that meeting, that families change, families are dynamic, and that treatment needs to be flexible to do that change, and sometimes I hear it referred to as sort of the dance that has to go on between a family and the treatment center to meet their needs when they're ready for that. And the graphic on the cover of the monograph with the mobile was sort of a central theme of the different family members and their needs and different timing that may be needed to look at their services at different points along the continuum. That last bullet on this slide, which those of you who've been working in the field for so long recognize that the complex family needs of children and families that come into substance abuse services and into child welfare services really takes an extraordinary amount of work across systems and that coordination across systems. So this is not information I don't think that's necessarily new to you. But in addition to that, as we looked at ways in which gender responsiveness is important and cultural competency and what that means with working across systems, with working with staff development, with meeting families where they are as they're getting started into the services. And I won't go through each of these, but I think some of the things that are important in this world of recognizing that substance use disorders are chronic but treatable, it presents some real challenges with that other bullet on this slide about safety comes first. And safety always comes first for both parents and for children. And when we're looking at a chronic disease, that becomes a challenge often when we're working across systems and trying to achieve outcomes. One of those pieces that comes into play in thinking about treatment and where treatment begins and ends with an idea, a principle of moving towards recovery is recognizing that this process of change in which the family member who's affected by the substance use disorder achieves abstinence and improved health means that wellness and the quality of life is what we're striving for across the family. And as we look at treatment as being one component in a recovery-oriented system of care, means that we're able to build on the strengths of each of those family members in order to help them achieve this wellness to be able to reintegrate into the community and into a way that they are able to sustain their own personal health and wellness and that of their family. So this continuum is sort of the guts of the monograph in terms of trying to understand where we've been and what the continuum of family-based services looks like. If you look at the left-hand column, that women's treatment with family involvement is really where we were around the time of the cocaine epidemic of the late 1980s and the early 90s, that the recognition that women recovered differently and that family members were a key component and a key sometimes barrier and sometimes strength that women came to treatment with in terms of their children and the needs that their children may have. And that early recognition that women recovered differently than men was really focused on a goal of improved outcomes for that woman with the substance use disorder. And then in those early efforts, which many of the providers in Florida were part of those early efforts to understand if you are serving a woman with a substance use disorder, that children often must accompany them to treatment. But in those early days, there weren't a lot of therapeutic services for children. Sometimes there was child care and transportation, and we see that in early legislation that was the emphasis on having child care made available. But still the focus of the outcomes being achieved were focused on women with the substance use disorder. And towards the mid-90s, late 90s, more and more recognition that the children that were coming to treatment with their mothers had significant, perhaps sometimes, issues that needed to be addressed in their own right, that the mother's role as a parent needed to be attended to in order to address the needs of the children. And that era, if you will, of increasing the attention between mothers and children and parenting focus in particular was the focus of this period. And then we've moved more specifically that when children accompany women to treatment, that each of them needs their own treatment plan. The recognition of sometimes the neurodevelopmental issues for children if they have been prenatally exposed, sometimes the environmental issues that they have been living in mean that they need some mental health services and certainly some prevention and intervention services in their own right. And again, this transition to focus on, even in the grant programs that were coming out, that there was a recognition that it wasn't okay just to measure the mother's recovery, that there needed to be a focus on the child as well as on the parenting relationship between the mother and the child. And then if we look at where we're going, and certainly some of the providers that are on the phone today and around the country have moved to this era of family-centered treatment, that goals focus on not just the woman and her child and on her parenting, but certainly the role of the significant others that are part of her life, her spouse, the children's father, the other support system that women may have available to them, and certainly the other support service and support system that they need as they re-enter into their community and focus on safety of their child, safety for themselves, and reintegration into the community. So this continuum, if you will, we sort of can find all substance abuse treatment agencies, I think, somewhere on this continuum. And the increased recognition that moving towards that right end of the slide, that goals for improved outcomes for women, children, and their other family members means that we're focused on improving parenting and measuring outcomes related to better parenting and family functioning. So as this group looked at the continuum and moved forward, some of the ideas that were put together related to this next slide in terms of how you categorize the multiple challenges that families face when they're coming to services. That there's a recognition that there's a need for clinical treatment for services that are delivered in mental health settings and substance abuse treatment settings in the immediate sort of sphere of the treatment agency, and then a set of clinical supports that have to be put in place, and then again those community supports that are needed as families transition and live in their community and need to put those community supports in place as they transition out of the immediate treatment piece of that recovery-oriented system of care. So in the clinical treatment system services, each of these kinds of services were defined and operationalized, if you will, in the monograph so that there could be some common understanding across sites, across states, across communities about what are we talking about when we talk about the medical and the biosocial issues that women present with and women and their families present with in the kinds of services that they need. So these were kind of looked at as the core of those clinical services. And then supporting that core, and in particular things like life skills, education, the employment readiness, the legal system and the child welfare system, and what that means to create those collaborations that cross the systems to ensure that families have access to these other clinical supports. And then that larger circle sort of supporting that with the housing in particular that we know is so critical. And again, the child care, transportation, the linkages to income support when that is needed, and obviously the vocational and educational services that women and their families need. So this idea that there are enlarging circles that treatment providers have connections with, but sort of naming them and operationalizing them was sort of the goal of this group getting together and saying, okay, so if we can put these services together, what are the next steps? And one of those was to do that same process for the needs for children. And the ideas that children have their own treatment plan means that many of these same sort of clinical treatment services that women need are also needed by their children. But some differences, particularly as you're talking about substance abuse education and prevention for these kids, trauma services for the kids, and therapeutic child care and developmental interventions when needed, that there is a set of services that providers are increasingly putting together to serve the children. And similar kind of approach with supportive services to those clinical needs. So in looking at those boxes, if you will, that are operationalized in the paper about what do we mean by family-centered practice in the world of substance abuse treatment, you might say, oh, that's great, that's a lot of boxes, and yes, we probably understood that already, that women and children need these. So we were asked to kind of go a step further and say, okay, if you are a community that is trying to provide comprehensive family-centered services for families, what do we do now? How do we get a handle on ways in which we can fund those services? So again, Kim Dennis from the staff at Children and Family Futures was the lead author on this monograph, and I often say bless Kim because she did a level of detail in putting this together that I think many of us would be very daunted by. But our purpose and our charge from CSAT was to identify strategies that increase funding flexibility, to look at some of the practice that's in place in order to maximize revenues and to look at the efficiencies of existing resources in a community. And by that, we meant that we would look at the federal and state funding streams that could support treatment services in this comprehensive way. And to do that, we also highlighted the experience of Shield for Families, which is a comprehensive family-centered treatment agency in Los Angeles, so that we were using their experience to say, and what does that mean if you're going to be in the real world of trying to apply these principles of family-centered practice, as well as try to look at ways in which you're providing comprehensive funding. So the monograph does a few things, and in particular sort of walks through some steps. And one of those first steps says that there's some prerequisites that, if you will, changing the funding stream is what many of us have to do oftentimes, particularly in these times of lean resources for services. But understanding first your own program, your own community, and ways in which you can do that, taking stock of those resources that are there and the needs of families is a prerequisite before even getting into what some of those funding strategies are. So we provide some tools about how to look at the inventory of existing funding streams across many of the federal and state funding streams that come into a state government, how that then flows into your community. How are they allocated at present among different service providers, how they might be looked at in terms of efficiencies and how allocations are made at present, and if there are funding streams that an agency has not already been part of receiving services or receiving funding from that funding stream, what's needed to tap into those existing resources? Is it a partnership that needs to be created, or is it a way that contracting could be done differently? And taking stock begins with really, knowing ourselves. Who are our clients? What are their needs? What changes have happened since perhaps a decade ago when we know substance use patterns have changed? Approaches in child welfare have changed. Ken mentioned the decrease in the number of children in out-of-home care as child welfare has changed dramatically across the country to really put services in place to keep children from being placed in out-of-home care. What changes does that mean have taken place in our own community in terms of resources that are available and ways programs are organized? The second step of that was really financing for what? What are the priorities, knowing who our families are? What are the priorities about what our women, our children, our fathers need in order to provide those clinical treatment and supportive services? Now, some folks would say, well, we don't have the data system. We can't get access to that data. I don't think this is necessarily the case in Florida, but in some other states we would hear, well, we send the data to the state. We don't get it back. We really can't do that kind of analysis to really understand in depth who the families are who are coming into our community needing services. So there are some other strategies that are certainly possible. Using case reviews. or surveys or focus groups, bringing together a set of parents to ask them, what worked? What do you need? What are those changes that have happened in the system that we need to be able to address? And what was most useful and what was provided, and perhaps what was needed but not provided while that particular set of parents were in services. Those can be very powerful tools to bring together families and ask them what worked, what else did you need, and to use that as a way of, again, knowing your own community, taking stock of your program. In those needs identification, what is it that we're providing internally, and what are others in the community already providing? What are those partnerships that are possible with looking at the priorities that parents tell us or our data systems tell us are needed with the existing program services? Recognizing that the parents are typically always involved with multiple community service systems, probation in particular, mental health services, and a host of others that certainly come into play as we look at those, again, those boxes of the service packages. How do we recognize where most of our parents are also involved? How do we take a look at those connections and look for those partnerships that are needed, because a lot of our parents are already receiving services in this other community resource. How are those other services being funded? Are those resources sufficient? I like the story that came from a community in California that they desperately needed post-treatment housing, if you will. They needed a place where parents who had been reunified could live with their children in a safe environment, and it was a community that had been heavily impacted with the rise in housing costs in California. And as they looked at this particular need, that they were not able to reunify some families because safe housing wasn't available, the child welfare administrator and the substance abuse treatment administrator went together to the board of supervisors and made the case about the resources in the community are not sufficient at present for us to be able to allow children to be reunified with their parents as quickly as we could for purely safety reasons. So are those resources sufficient, and is it not just my own resources, but is it the other agencies' resources that our families need, that this partnership to go together could be much more effective and receive a much greater impact if we were looking at how we do that together? Now, I don't mean to be somewhat Pollyannish and say all of that happens so easily and that it doesn't take a tremendous amount of effort, a tremendous amount of will by agency directors, by program managers, by frontline staff to look at these challenging issues about collaborative practice and how you work across systems. But we certainly know that there are examples in which that has been done. Then after really understanding what are the needs, what are the existing resources, how do you create the inventory of those funding streams that come into the community and how to tap into those public, sometimes private dollars and really get a handle on where are those funding sources, where are they being spent now in order to understand how to meet the needs of the families that we're trying to serve. And again, who is in control of those resources? We have done some work in one state that found that some of those barriers that they were sort of living with in the funding stream were not federal barriers at all. They've been blamed on the feds in terms of those are things that we can't change. But when they really got into the inventory and said, this is what's coming into our system, this is the way that we're allocating these resources at present, how do we look at those resources and how do we figure out who controls those resources and what flexibility we might need? And lo and behold, many of those things were happening at the state level and not necessarily at the federal level. And so there was flexibility to be had by working with their state agencies and their legislature. So once again, after this process of really knowing yourself, knowing your community, knowing those funding streams, what new partnerships might need to be established? What potential collaborators are there in terms of providing the comprehensive services? How do you initiate those discussions? How do you really reflect the family and the community needs in the way in which the partners come together to meet those needs? One of those key questions is, if the resource mapping says, we have this significant unmet need, those are then critical decisions for treatment providers, for child welfare agencies, for the CBOs to look at those and say, is this something that we need to control in-house? We need to purchase that service. Or is that something that we can partner with in order to get that service for the families that we are serving? And sometimes those are very difficult decisions to be made. And sometimes those are the things when the rubber meets the road, if you will, about making some decisions about is this something that the treatment agency needs to purchase? Is this something that the child welfare agency needs to purchase? Or are there providers in the community that are providing that service that may not have the specific focus on our population of those families at risk of child abuse and neglect that need services from treatment? Is there a way that those community resources could be brought to the table and made more flexible, or ways in which some of their administrative rules may need to be looked at in terms of serving this particular population? How do you make those planning and decision makings and about the funding streams? So a list of steps to go through in this taking stock of your program to really understand more fully what that would look like. And then the monograph discusses ways that we can look at unified financing, sort of one of those newer terms that folks are using, to look at community resources in a unified way that really maximizes the funding, maximizes the flexibility, and looks at efficiencies in existing resources. And some definitions. Again, we've since and we're told there's a need to establish some common definitions. And some of these things have gone on in child welfare practice, some have gone on in mental health, some have gone on in substance abuse treatment in terms of trying to define these different ways and to look at flexibility. Certainly the decategorization movement of the 80s, that things at the federal level were put into block grants and given to the states to distribute to their communities. We're certainly familiar with that kind of approach, and some of those discussions go on around some of the entitlements today about, is it better if you decategorize those entitlements and pass them in a block grant to the state? So that's what we mean by decategorization. Ways in which a community or at the state level may be able to pool funds. There's a state that does this with their child welfare funds to a great extent, that pools at the state level and counties tap into that pooled resource in a way that makes it much more comprehensible, I guess you would say, to both the counties and the families that are trying to get services across multiple funding streams. So pools or blended funding. Or other terms with using braided funding, which is very closely aligned to what we talk about in the ways that wraparound services are put in place, so that it may be seamless to the family who's coming into services, but in fact behind the curtain, if you will, there's a variety of funding streams that have been pulled together in order to provide this comprehensive package of services for the family. And then ways in which communities can look at resources in terms of maximizing their flexibility, maximizing the federal funding by looking at the ways in which matching goes on, what's contingent on state or local or private spending, to really understand what's possible. We were in a state once that had a large amount of a state resources going into the state substance abuse agency, and those resources were state general funds, and they were not being matched with any of the ways in which providers might be able to use those funds to leverage additional Medicaid or other resources that are available through entitlement. Looking then at financing in terms of those entitlement funds and ways in which leveraging can happen at the local level, and making sure that those possibilities about administrative claiming, particularly when you're talking about families that have very similar needs in case management and administrative kinds of funding sources that happen in child welfare, and they may be happening in substance abuse treatment, but it may not be claimed in substance abuse treatment, although it is the same function, and ways in which those services can be looked at about what's the right way to do that contractually to make sure that we're maximizing and looking across those funding streams. And then some of those harder questions, looking at some of the things that have happened in institutional care and moving towards wraparound services, of redeploying those resources in the community. I think we've all had some experience now with what that looks like. Many of those cost savings have already been generated, but the tough stuff comes in when you look at, well, and so what's effective? What do we want to continue to invest in? Are all the providers getting the best outcome for the resources that are being invested? Is there a need to have a redirection agenda? How do we match what the outcomes are and the efficiencies in those services in order to make sure that we are providing the services that are needed and providing them in the most effective way that we can? So then the major piece of this monograph is the work that I spoke about that Kim Dennis did in the detail. In each of the primary federal funding streams, we've provided a great deal of detail in understanding those funding streams that can come into a state and be used for any of those, if you will, the boxes that we showed during the previous section in looking at clinical treatment, clinical support, and community supportive services. Looking at those funding types that cross the federal funding agencies, and looking at the ways in which each of those funding sources come into the state and are possible funds for any of those services that were identified that are needed in comprehensive family-centered practice. So each of those federal funding sources for adults are identified, and each of those federal sources for children and youth are identified. And then the monograph goes into each of those sources with some fine-tuning. I know the monograph is a couple years old, so some of these may not be completely up to date in terms of the size of the funding stream, but most of these don't change dramatically from year to year in terms of the type of funding, how the funds are managed, who's eligible for that funding stream, how substance abuse treatment providers can leverage those funds, what are the restrictions on that particular fund, and then sometimes there were some special notes that needed to be put into the monograph for each of those federal funding streams that were identified. So in wrapping up a bit, how we look at ensuring that families' needs drive the funding search, that there's a way and some steps to map the funding streams in the community, looking at those questions that need to be dealt with in terms of developing a collaborative relationship or providing the service themselves, looking at ways that funding can be diversified within an agency, how to prioritize which targets for funding based on the needs of the families that we're working with, and importantly, particularly, increasingly importantly, I guess we would say, as we look at funding and what we need to be looking at in terms of effectiveness, and efficiencies in treatment agencies, in child welfare practice, in all of the community partners that we're building with looking at the outcomes that are being achieved. And then some steps to look at the rules and how to give some guidance on what flexibility might be available and how to move forward with making that possible. And the monograph ends with a discussion about sustainability and the ingredients of sustainability. Once this process has been identified and the collaborative is working, how to really look at the programs that are needed to be sustained, what the outcomes are, how to achieve the partnerships with the policymakers for them to understand what the outcomes are, and to be building those relationships over time, because it's not just the financial support that's needed, there's also the political and community support that are all key ingredients at being able to sustain programs over time. With that, I will turn things over to Ainsley from the Village in Miami and have many more concrete examples about how the Village has taken these principles in providing services for women and their children.
Thanks, Nancy. You gave us a good background. That was great. Welcome, everybody. My name is Dr. Ainsley Stark, and for the past few years, the Village has been fine-tuning our treatment program to include the family as a whole, and I'm here to describe what we're doing and to give you the therapeutic approach that we have taken under the foundations. So you may say, well, what is family-centered treatment? We're doing family-centered treatment. We have a mom and we have the child, and dad comes once in a while, or uncle comes. There's actually a pretty specific foundation. And it really means that the problems and solutions are defined within the context of the family and the family's strengths and resources. What that really means is you're looking at the family as the unit of service. And the definition implies a focus on working with families, not exclusively working with individuals in the family system. And there has been a paradigm shift in the last couple of years, especially for us at the Village. As I said, we've been working very hard on focusing on doing family-centered treatment. And some of the key features are collective treatment, not individual treatment, considering the family as the identified client. And I think that's a big shift for us, because we had always taken one patient and utilized that patient as our identified client. Family participation is obviously required, and it's the quality of the services, not the quantity, and we'll get back to that. Next slide shows you a little in more detail or graphically about this paradigm shift. And as you can see on the side, the old way we used to do things was parallel or sequential services, and that actually bottoms off on one of Nancy's slides that she had earlier, where you did services for the child, you did services with the parents, and you did services with other family members. Now we're trying to integrated services where all of services are integrated together. And the next diagram will show you what I mean by that. We work with the family. If you can see on the outside, the family counseling and the family needs, we work with the family into the individual. So the individual needs are integrated completely with the family. And the family is the target of treatment, not just the individual. And I'm going to fill that in for you so you can see how the whole circle works. It's a different approach for clinicians. It's always hard initially to change your approach, but there is a completely different approach. The family unit becomes the focus of treatment rather than solely the identified client. The assessment evaluates not only each member of the family unit, but the family system itself with a focus on family functioning. So we really want to look at the family dynamics. You must understand the interactions and transactions amongst the family and the problems. The family is involved in determining needs and planning of services. So that's also another shift. In the old way, sometimes clinicians used to say, well, this is what you need in order to get clean. Now we look to the family as a unit to decide what they need in order to get better or round as a family, both substance abuse and mental health. For example, Some of the issues we have is that a mother who's the identified client, her substance abuse probably will impact on her parenting. It will impact on behavioral problems for the kids, and so we need to effectively provide the whole family with coping skills in order to further treatment, not just the mother. It's what we try and do is enhance family protective factors and build on strengths. We use multi-agency approaches and interagency collaborations. As you know, there is no way that one agency could do this on their own. Particularly when giving family-centered treatment, you really have to rely on a lot of collaborations. We try and use services that affirm and strengthen cultural, racial, and linguistic identities. These are services that the family identifies. These are the cultural, racial, and linguistic identities that the family themselves identify with, not that you, the clinician, would decide. Services and approaches should be diverse and flexible. And what that means, if a mother needs why services have to be a little bit flexible. In the old days, if someone was coming in for substance abuse treatment, and they had a mental health issue, we may have treated them both together. Now, if a mother is, say, psychotic or she's depressed, we would have to treat that first before we involve the substance abuse treatment, and at the same time, we may have to look at how that depression has been impacting the children or her spouse, or impacting, if it's a father, impacting the spouse on the other side. So it really is a collective family approach. Family engagement is essential, and that is something I know Nancy referred to as well, and it begins at screening. So what that means is when the patient contacts us, we explain the whole family approach. We start right away at the initial screening, and it continues in intake. We try and have as many family members included as possible in intake, and we identify the potential family participants. We try and include as many families to come into family members, to come into residential treatment. We then need to obviously obtain consent of the identified client or patient, and once that person lets us, we contact all the identified family members. So we can explain the reason and the importance of family involvement, and it really starts at intake and screening. The family is included in the entire process. They're included in the treatment planning as well, which is essential. And we don't give up. We try, if for some reason the patient or the client doesn't want family involvement initially, we really try and re-engage at multiple points of entry. When you're working with systems, one of the things we found that it must be collaborative and integrated. We also have to have a unified vision for the family. And I know a lot of us are working in different agencies and different departments, whether it's with child welfare or drug dependency court. And the approach here is that all of us have a unified vision for the family, because oftentimes if we have separate visions, it's not going to work for the family. And we include members from the other systems in all the treatments and service plannings. I know people are probably, oh my God, so what are you doing? You know, you've got one person sitting here in drug court and another sitting in child welfare. We do try and have open meetings, and when we plan the cases or case conferences, we try and invite as many people as possible to the meetings, or vice versa. As the clinician, we try and attend as many meetings as possible in order to unify the family. One of the best ways to do this is through comprehensive case management, because what happens is your case manager is the person who sets this all up. And it's the core function of the family-centered approach, and it needs to be, because it's family-centered, holistic and comprehensive. Now, the purpose is to develop an assessment and service plan that utilizes a strategy of intervention with a family over a period of time. And as you can see from the next slide, we go into why this holistic approach is necessary. As we all know, substance abusing families presenting for treatment have significant problems in addition to using drugs and alcohol. Many of the patients have mental health problems. They also could be HIV positive and have limited dental health. Some of the families have child welfare involvement. Children have many problems related to the caregiver substance abuse. There are sometimes limited vocational skills and employment histories. You know, maybe some of the family members have never worked. The actual family relationships are often very poor. And, you know, one of the things we've all come across is that there may not be any contact with biological fathers. And we'll get into that a little bit down the road, because one of the things Village is focusing now is on the involvement of the fathers. Peer relationships might also be dysfunctional or non-existent. And then we have issues with leisure and recreational activities, or rather the appropriate way to have leisure and recreational activities. And housing is a problem a lot of the time. So what the core principles of case managers are: a single point of contact. So it consolidates the responsibility of the family to a single person. And it's driven, again, by client need. And as you'll see throughout this presentation, one of the new paradigm shifts is that we are really going for what the clients need, not what we as the clinicians think the clients need. Also advocacy, promoting the family's best interests, and also pragmatism. Case management begins with the family. So we start where the family thinks they are. Also, it's anticipatory, which means that it requires the ability to understand the natural course of addiction and recovery, and to foresee the problems and understand the available options and take action with the family. It also is flexible. Again, we're looking at a very flexible approach to treatment and culturally sensitive. Engagement serves to orientate the family to treatment and to the rules and regulation of the program, so that's the first thing we do. First function of case management is engagement. Engagement, as you know, is key. That's what brings the family in, and that's what makes the family buy treatment. Then the next set is assessment, and it's a comprehensive assessment that focuses on the family's needs and resources. As you'll see from the next slide, another function is following from the needs assessment, planning, goal setting, and implementation form the core of the case manager's function. As does linking, and that's coordinating all the various services and integrating them into a unified whole. And then disengagement, which is one of the last functions, entails physical and emotional separation. So this would be a formal and a planned event, pretty much similar to discharge planning. Okay. So one of the things we start first is assessment. And comprehensive family assessment addresses the broad needs of the family, basically the big picture. You know, it's a big family, hopefully, so we have to address the big picture. And it addresses the presenting issues, the underlying causal factors for the behaviors and conditions, as well as the contributing factors, which could be substance abuse, mental health, domestic violence, trauma is another big issue for our families. The family assessment examines family strengths and protective factors, which is a very big role here. We are coming from a strength with the family, with comprehensive family services. We're coming from a strength-based model. We're utilizing the strength of the families and showing the families what strengths they have in order to complete treatment. The assessment also incorporates information from other assessments and sources, and it focuses on the development of a service plan, because obviously in order to, in all this talk, in order to do these things, we have to make a service plan to get the family through treatment. So what is usually assessed? Background and history, parenting practices, some of the ones I've gone inside: family fears, strengths and resources, support systems, problems with accessing basic needs. We've brought up housing, relationships, work. Just basic needs are a big problem for our clients. The parent and child mental health, parent and child substance abuse, domestic violence is another issue. As I said before, education, vocational, housing, medical, dental, problems in accepting responsibility, and patterns of social interaction. That's a lot of needs that need to be assessed. So that's why we have to do this comprehensively. So what we usually do with a standardized assessment for adults, we usually give out the addiction severity index, substance abuse subtle screening inventory, the mental status exam, comprehensive case management assessment, the PTSD symptom scale to assess trauma, and additional assessments as needed are identified will be psychiatric or a whole host of psychological assessments depending on the mental health involvement with the parent. And then the assessments we use for children are all developmentally appropriate. So we would look at the child, and depending on the age, we would give certain assessments. Some of the basic ones we use at the village is the Denver 2, the Bailey Scales of Infant and Toddler Development, the Child Behavior Checklist, the Youth Self-Report, the Peabody Picture Vocabulary Test, and the 2 WISCs, the WISC, which is for the little ones under 5, and the WISC, which is for 6 and older. And again, that depends on what the problems with the children are, and all assessments are tailored to individual needs. So we could give less or more, depending on what issues. So now we get to the service planning, and this is where you take all that assessment and you take all your initial case management ideas and your family and everything else, and you put it together to do services for the family. So how do you develop this service plan? It's based on the information obtained in the needs assessment, and it identifies and prioritizes the needs and the outlines specific goals for each need. So you identify the need, and then you would outline what needs to be done for that need. What the needs do is they understand the stages of change within the family. And getting back to the MI model, pre-contemplation, contemplation, preparation, and action. So we work everything within the context of those four stages of change within the family. And you always do a statement of need. You know, example, in this case, it would be education or housing. So you base it on the needs of the family. Then you would do specific goals to address the need and specific objectives related to the goal. Pretty much similar to what therapists know as a treatment plan, but this is a case management service plan. And then you would print out and identify some action steps for the families to perform to achieve these objectives. Again, always remember strength-based, so the families feel that they're based on their own strengths in order to change. This is developed as a collaborative effort with the identified client, the family, the treatment team, and other agencies if possible. And if other agencies can't participate, it should include the minimum services provided by other providers. So we're really trying here to get the whole team on board. One of the things we've also changed at the village is our treatment planning. We call it now a wellness and recovery plan. And the reason we do that is from a strength-based perspective, and it takes away the problems. And the whole thing saying problems, and it's something more positive. And we had just included a basic outline of this wellness and recovery plan, and you'll see in the later slide there is an example. So what should treatment planning be, or wellness planning? It should be an opportunity for creative thinking. It should be a successful strategy for managing complexity. It should be an opportunity to build alliances. And in this case, what's interesting, you're going to be building alliances between the therapist and the family, but also alliances between the family members, because each family member could identify what they wanted to work on in their wellness plan. It's a mechanism for acknowledging the hope and dreams of the client, and it's a means for ensuring person-centered care. And that's the key here, person-centered care. We're basing it on what the client feels they need. And it's a process for creating the guide for the journey. The plan should create an opportunity for collaboration, assure the assessment and services are culturally competent, describe strengths, needs, and preferences, and identify and establish criteria for successful outcomes and transitions. We need to also document the necessity for services and support service documentation and billing. So what are some of the benefits of a family-centered plan? You know, do I need to do all this? It sounds like a lot of work. Well, there is no question that it improves access to treatment. There's also better retention rates, and I think Nancy had mentioned that. Demonstrated outcomes that are goal-oriented, practical, clear, and meaningful to the client. So the client can actually see these goals and objectives and can actually have a plan to work toward, and then once they're completed, then there's a success in this, which is very motivational. It's strength-based and recovery-oriented approach to service delivery, and the inclusion of goals that are reflective of the informed choice of the client. The benefits of a family-centered plan also include improved access to, I think I have two here, so I'm going to go on to the next slide. Demonstrate outcomes that are goal-oriented, practical, clear, and meaningful to the client. And I'm going to repeat this. It's strength-based and recovery-oriented approach to service delivery and the inclusion of goals that are reflective of the informed choice of the client. So this is just an example of the village's individualized wellness and recovery plan. And it's very well thought out. Personally, for me, we started this about a year and a half ago. Dr. Frank Scafidi, who unfortunately couldn't be with us today, put this together. And initially it was like, oh my God, and then I'll go through it seemed like a very, very large treatment plan. And actually utilizing has been wonderful for us. From the point of view of the therapist to the client, it really does give the client a way to say what they need. Actually, I'm going to go back on the first page. I think, actually no, it's the second page. There's a life goal. Instead of doing, you'll see we use the word barriers instead of problems anymore, so that the client can identify some of the barriers they feel they have. And also the client, it says in the top here, you'll see, be written in the individual or family's own words. and includes statements of goals, aspirations, dreams, roles, functions, and the vision of life. And the client themselves identify the life goal, and then they identify a service goal. And you'll find once the patient has identified their own goal, it opens up a whole new world of how the service is driven and how treatment and therapy is driven. And personally for me, I find that it has made therapy, I feel, much better for client and therapist. And this is something you can go through at your own leisure. And I guess that's it. Do we have any questions? Am I going to turn it over to Ken or Ron?
I'll take it back, Ansley. Thank you very much. Thank you. Reminder, everyone, if you want to submit questions, we are taking a look at those. And you can do that, as Ron indicated, via the chat, as he discussed earlier in the presentation. If you have a question about that, just let us know, and we can help you with that. A couple of comments that I'd like to make. These are tough financial times, if you will, and situations, and we work with a lot of sites around the country. So Nancy mentioned some of the challenges associated with funding. Probably as most of you did, sat in and listened to Governor Chris' State of the State last night. The collaborative practice that you have been engaging in and you're engaging in now as innovation sites also provides an opportunity to demonstrate the impact you're having on families across systems. That is the joint outcomes of serving families in the child welfare system, how they're benefiting from substance abuse and mental health services, and can you demonstrate an impact in some of the core child welfare outcomes, like children being able to remain at home, like the length of time and then the number of children they're able to be reunified, the length of time to reunification. Even in these tough budget situations, and we're not alone here in Florida, but even in these tough situations, you have a bit of a leg up by being able to demonstrate and measure those cross-system outcomes, and the fact that you're working collaboratively, I think, puts you in a better position to demonstrate the work that you're doing with families and the impact that you're having on families. The criticality of this work in Florida is known to you in working with families every day or in roles that support direct service workers who work with families every day. Some of the discussions that we've had on a statewide basis, I know some of the advocacy work that's occurring reminds legislatures that in 2007, if you look at Florida's APCAR's reporting for out-of-home care, 18,000 children removed related to parental drug abuse in 2007, and 3,000 children removed related to parental alcohol use. So again, the work that you're doing, the cross-systems work, the impact on families, not just in one system or the other, but by doing that collaborative work, by doing the work that you're doing, being able to impact families in multiple systems, and particularly in the child welfare system, is pretty critical. I want to highlight some of the resources. You probably, those of you in Miami, are hopefully familiar with this. The Engaging Moms program that was developed by the University of Miami with Judge Cohen in dependency drug court. Judge Cohen's court just received another grant to expand services, a family treatment court grant from the Office of Juvenile Justice and Delinquency Prevention, and they're expanding this Engaging Moms protocol, if you will, or model, using caseworkers at the dependency court level, assigned to the court to engage families in really a family-centered approach as well, and not just doing traditional case management, but doing work with spouses and or significant others and caregivers as well, other caregivers as well. And so here's a reference to the publication, and I know that this is being expanded in Miami, and there's interest in looking at this in other parts, in other jurisdictions, doing family drug court work as well. I mentioned earlier the challenges of engagement and the critical component of engagement, and this is exactly what this model is about. We discussed earlier the two family-centered monographs that are SAMHSA publications through the National Center on Substance Abuse and Child Welfare, and you have those available to you. There's some additional resources. The next one that we want to mention is one that is still under review and available in draft in the use of substance abuse specialists in child welfare agencies and dependency courts, similar to what we just talked about regarding engaging moms. This highlights a number of jurisdictions around the state and how substance abuse specialists are used. There are different models around the country for using substance abuse specialists. Some are using parent partners. We work with a site in Iowa that uses moms in recovery who have lost their children in the child welfare system and had them returned as a result of their own recovery. And so that parent partner model is one model. Here in Florida, we have the family intervention specialists, substance abuse professionals that are embedded in child welfare agencies to help with not only assessments but linkage and support to help families access substance abuse treatment. So this is a monograph that's soon to be released, soon to come out and available, and we'll make that available to you as soon as we get final release clearance from SAMHSA. These are the citations for much of the material that was discussed today. A couple other resources I want to mention. I mentioned earlier about work in the innovation sites. Part of the engagement with the National Center on Substance Abuse and Child Welfare with the state of Florida is, I mentioned, looking at some of the processes at a statewide level and some of the screening tools, in-home family assessments, safety assessment, et cetera, for how substance abuse and mental health issues are integrated or incorporated. And I mentioned working with the innovation sites. One of the things that we talked about in our plan is that it's really important that we work locally and work with you in the 3 innovation sites to understand what you're doing around collaborative practice and any recommendations that we might make. Excuse me, my chair just collapsed. Any recommendations that we might make, we really want to see what you're doing locally and how we can incorporate and integrate our work and support the work that you're doing locally as innovation sites. And having been here in Florida, I know that all of you have been working collaboratively for a number of years, so we want to take advantage of your learning and also bring to bear some of the other resources and experiences of other parts of the country, particular issues that you may be experiencing. So we want to do follow-up from today's webinar, and both Pam and I will be contacting each of the innovation sites to schedule some time when we can talk about how we can support your work and schedule some time when we can come on site to connect both the work that we're doing as a national center with the work that you're doing as an innovation site. You see some of the resources that we put up earlier are available on the National Center website, PDF versions. There's 2 other documents that we will bring with us when we come on site and walk you through those and share some of the information in those documents. One of them is called SAFER, Screening Assessment for Family Engagement, Retention, and Recovery, which is really a guidebook for doing collaborative practice, both collaborative practice across child welfare, the court system, and substance abuse, and really addresses not only things like screening and assessment and engagement, but also stresses the importance of communication, the importance of collaborative practice. As we look at tools and instruments and much of the work that we've done around the country, and I'm sure this is your experience locally, it's really not about a particular instrument or a particular tool, but it really is about how systems work together or fail to work together, and that to the extent that that collaborative practice manifests itself through, whether it's through multidisciplinary case staffings, through joint referral processes, through ongoing communication, through the sharing of data and measuring joint outcomes. It's really the collaborative practice that makes or breaks what is good practice in linking these multiple systems and linking child welfare, substance abuse, to courts, and in mental health. We want to work with you to identify opportunities to strengthen that collaborative practice and to reinforce it where that's working well. The other tool that we'll bring with us, or the other guide, is Understanding Substance Abuse and Facilitating Recovery, a guide for child welfare workers. It's a brief monograph and a nice reference and overview for child welfare workers and working with families with substance use disorders. We're doing some work in Jacksonville, and they've just ordered 300 of these guides to put in the hand of every caseworker in Jacksonville as a tool to assist them and support to assist them with working with families with substance use disorders, which constitutes a fairly high percentage of your caseloads in the child welfare system. You see our Director of Technical Assistance, Larissa Owen, and her contact information. Let me give you my contact information as well, and I can be reached at KDECERCHIO, and we'll follow this webinar up with this information as well, but KDECERCHIO at cffutures.org. So feel free to contact me directly as well with any questions that you might have or additional information or resources that we could bring to bear as well. And I want to quickly browse and see if any questions have come in, any content questions for anybody to address, any of our presenters to address. And unless I'm mistaken, I don't see any questions right now. Ron, am I correct about that?
You're correct, Ken. There haven't been any questions come in. I'm putting up a slide now to show folks where they can click on the Q&A icon the Q&A icon to submit any questions if they have any at this time.
The other thing I want to remind folks is the evaluation. And if Ron, if you could speak to how we're going to, we have some evaluation. I think there's, in a minute, we'll show up a slide where you can give us some feedback on today's webinar. And equally as important as make suggestions for future topics. We do webinars really throughout the country on various topics related to collaborative practice, including the SAFER manual, including the substance abuse specialist. So if there are topics that you think would benefit your community and your staff and your partners, feel free to make those suggestions to us as part of the evaluation of today's webinar.
Yeah, Ken, we still have not received any questions.
Okay. Ron, if you would put up the slide for evaluations. There are the evaluations.
Sure, yeah. So we'd like everybody to please take 30 seconds to fill out our evaluation. You can access it from the Center's homepage at www.centerforchildwelfare.org. That's Center for Child Welfare, all spelled out with no spaces, .org. I'm going to bring the website up here for you. When you go to the website, you'll see the home page here. If you look over here on the right-hand column under Center Announcements, right here it says click here to access the Family Center Treatment for Women with Substance Abuse Disorders webinar survey. Click on that link there, and then just take a few minutes, and there's only 5 or 6 or 7 questions. If you can answer that for us, we'd appreciate it very much. Thank you.
Okay, thanks, Ron. And with that, we thank you for your time, for taking the time out of your busy schedule today to join us. Pam and I look forward to speaking with the court team and your leadership in the coming weeks to schedule some time and when we can come on site, and look forward to reconnecting with all of you personally in the coming months. We wish you well with your continued work. There are no magic bullets. From time to time we get asked, well, Chief, just tell us how to do this. It really is, I think you know how to do most of what we're talking about. It takes a lot of hard work, and we're looking forward to supporting your efforts and bringing to bear our experiences, both in the work that we've done here in Florida and the work that we've done through the National Center around the country. And with that, I also want to thank Ron and your team for coordinating today's webinar, and thank Dr. Young, Nancy Young, and Dr. Stark, Ansley Stark from Miami for your presentations today. And with that, have a good week, and we'll see you soon. Thank you.